Hello and welcome to Coronavirus in Texas, a virtual event series from the Texas Tribune. I'm Edgar Walters, and I want to thank you all for tuning in. While the Tribune has paused our in-person live events, we're moving the conversation online with an ongoing series of virtual interviews. I'm here today with Andy Slavitt, former head of Medicaid and Medicare under President Barack Obama, and we will be discussing the effects of the current outbreak on the American healthcare system until about 12:45 p.m. Central Time this afternoon. Mr. Slavitt and I will also be going over First, I want to thank our sponsors for supporting today's event, Texas 2036, Blue Cross Blue Shield of Texas, AT&T, Ascension Seton, and the Texas Association of Health Plans. We also want to thank KXAN and KPRC2 for their media support. And nota bene, though donors and corporate sponsors underwrite our events, they play no role in determining the content, panelists, or line of questioning. So let's get started. I'll introduce Andy Slavitt. He oversaw Medicaid, Medicare, the Children's Health Insurance Program, and the Health Insurance Marketplace programs under President Barack Obama. He's the founder and a general partner in Town Hall Ventures, which invests in innovative healthcare businesses. He also serves as chairman of the nonprofit United States of Care, which focuses on increasing access to affordable healthcare, and as a senior advisor on the health policy to the Bipartisan Policy Center. He's also the host of a new podcast, In the Bubble. So, Mr. Slavitt, I wanted to start with the news of the day, by which I don't mean injecting bleach. What I mean is we are expecting an announcement from Governor Greg Abbott here in Texas on Monday about steps to reopen the economy. And while we don't know yet what exactly that will look like, we got a preview today in Georgia, where they have reopened gyms, restaurants, and salons. Do you think that's premature at this stage of the pandemic?
Yeah, I mean, I think they should really only be opening tattoo parlors at this point. No, thanks for having me, Edgar. Good to be with everybody. And look, I think it's interesting. The obviously our public officials, governors, White House, everybody feels a pressure, as we all do, to try to move back to normal life, find ways to move back to normal life. But the public has been saying it pretty overwhelmingly is we do it, we want to do it safely. We don't want to put ourselves at risk. And, I don't think that any public official, whether it's the president or a governor, has the ability on their own to say we're going to open the economy. Consumers will only spend, and employers are really only going to be hiring based on their views, among other things, putting aside the oil situation, the energy situation in Texas specifically, but more broadly, if they feel like there's a real plan that could be effective on the public health front to contain and minimize any outbreaks as they come out. So people are going to be deciding for themselves. And so if the governor comes out with some reasonable things that are sound and keep people safe and allow some people to get back to work and to test some things, I think that's fine. But
what do you mean by reasonable? I guess if you're advising a governor or somebody in this situation, what is reasonable versus unreasonable as far as reopening?
Yeah. So look, I think what you don't want to do is you don't want to be creating new hotspots by taking employers where there's a lot of in and out action, where it's very hard for people to be safe, and allowing them to go back into the work environment. So people who have computers, work out from computers, they still ought to be very likely the safest thing to do is work from home. If you have, now if you want to go play a round of golf, right, and can do that safely, or if there are other kinds of businesses that can open safely and that people will want to access for, then I think that's another story. So as long as we're not putting people in harm's way, because remember, we're putting essential workers in harm's way as it is. We are asking people to take risks, and so if we expose more of ourselves to things in an unsafe way, then we're going to be potentially risking people who don't have a choice. And that I think is something that all of us have to take responsibility for. The good news is the evidence that people are. 80% of people say that they believe that staying home has been the right thing, according to the latest Kaiser poll. Most people, the vast majority of people, say even though there has been sacrifice, in some cases significant sacrifice, they intend to continue to stay home. And so I think people are getting wiser and wiser about what are safe activities for themselves and their families. And I think that's really going to be the gating factor. Having enough tests, having enough ability to contact trace, having enough containment, then I think you'll start to see things move forward. Until then, I don't think it matters much what a governor says one way or the other.
Yeah, I'd love to return to those points about increasing testing and contact tracing. But before we do, one kind of general question that we keep getting from our readers is how and when, but really how does the shutdown end? And what does that look like? I mean, should we be telling the public, brace for this for the long haul? If so, how far ahead are we looking in the future? Kind of, can you walk us through the long-term planning that goes on in a crisis like this?
So look, let's all acknowledge that we are really early, and there's a lot more we don't know than we do know. So, everybody needs to, I think, take a little bit of a deep breath and give everybody a break. The people are all trying to figure those questions out, and no one knows the best answers. They're trying to carve a path. They're trying to balance two very difficult things because nobody likes to be without income or without their social support structure, and nobody wants to expose themselves to bad public health crises. I think the best path is going to be to understand that there probably are no silver bullets, at least in the short run. There may be medicines that work, social distancing works, the testing and tracing work, but they all have drawbacks. In each case, we're not eliminating the virus. There's one way to eliminate the virus, and that's to eliminate all human contact with one another. We're not going to do that. So we have to figure out how to live our lives the best way possible with and minimize the risk, protect people who are particularly high risk. And so that will mean it's going to be gradual, and it'll mean fits and starts. If you look back at polio, smallpox, the 1918 flu, there were a series of openings and closings based on conditions on the ground. And so if we are giving our scientists more time, if we are giving our hospitals enough of a break so that they have sufficient equipment and they can handle whatever cases arise, then at the very least what we're saying is nobody is going to die because they can't get a hospital bed or a ventilator. That in itself saves a lot of lives. Yeah. If we send public health officials into nursing homes and make sure those are safer, that'll save a lot of lives. And then I think there'll be some limited gradual things we can do. And then there'll be some big, tough decisions like schools in the fall and things like that.
Yeah. It's just that, time is money, right? And we have seen a willingness from Congress so far to increase spending, stimulus checks to people. But the longer you ask people not to work, the more income, they're potentially foregoing. I wonder politically, how long can we expect that level of willingness to spend, frankly, to last?
I think it's political, not economic, though. I don't think we're asking people not to work. I don't think that's the situation. I think employers are not investing and will not be investing, and consumers will not be spending so that employers want to invest until such time as they feel the situation's right. It's not as if the Congress and the president, if everybody had the political will and said, let's reopen the economy, it wouldn't work. It wouldn't work because in limited fashions, it would maybe, younger people would go to restaurants and bars and so forth because they're feeling relatively immune, but they don't have a lot of spending power, right? So we can. I wish we had a choice between the economy and public health, and that we could wrestle with. I don't believe we actually do in the main. In the main, I think whether it's the market, whether it's investors, whatever it is, their people are not going to be comfortable going back to the old way while they feel there's serious risk. So the truth is, at least for the short and intermediate term, we are going to have a government spending fueled economy. Doesn't mean there won't be some industries. Doesn't mean we won't start to manufacture drugs here and some other things, or that there won't be some new and brighter spots of the economy. But we've got global deflation, we've got no interest rates, and we are spending our way to avoid a massive depression. So the federal government may not like it, but they also don't have a lot of choices in the matter. So the president and I think many of the governors would love nothing more than to try to kickstart the economy back to normal in the fall, not the least of which because it's political season. If we have sufficient protections in place across the country and people feel safe, then it's possible that can happen. It's more likely that it's going to be a little longer. We're going to be in it for a little while. And while it's hard for us to fathom because we don't have the context of it, this creates a very difficult situation for most Americans. Yeah. And there's no simple answers.
Let's talk specifically about a pretty sizable chunk of the economy here in the U.S., which is the healthcare sector, where, in kind of an ironic and cruel twist of fate, at the moment, healthcare workers and the healthcare industry is kind of most needed. They're also facing, they're certainly not immune to the economic pressures that everybody else is seeing. We're seeing, independent doctors' practices potentially having to go out of business, furloughing of staff, even emergency room doctors working through this, seeing, pay cuts. In the U.S., we have traditionally relied on this model where health insurance is tied to employment. Why should that continue after this crisis, given what we have seen as far as, massive numbers of people becoming unemployed and losing access to health insurance at a time when, healthcare is kind of top of mind for everybody?
So I think you're raising two different questions here. One is what's happening with the healthcare sector and workforce, and the other is the sort of coverage question.
Yeah, let's start with coverage.
Yeah. I mean, look, it's a question I get asked most frequently, which is, surely this is going to mean that the country is going to think radically different about healthcare coverage when we come out of this. And I'm not so optimistic. I guess I think of it this way. It will depend upon whether or not coming out of this, we view this as similar to the way we viewed the crack epidemic or the way we viewed the opioid epidemic. And here's what I mean by that. The crack epidemic, from the standpoint of policymakers and people in power, happened to other people. And our policy response reflected that. There was not a lot of money going for treatment. There was criminalization. It was because people felt relatively safe and protected from it. There was a lot of now where the opioid epidemic, people felt like everybody knew someone impacted. I'm not saying that the policy response was great. What I'm saying is there was an across the board, Republican and Democratic, bipartisan, we've got to do something here because it's in every rural community, it's in every urban community, it affects rich, it affects poor. And because we saw ourselves in the problem, our response was different. Today, when you look at this crisis, it's starting out having a disproportionate effect on lower income people, on people in nursing homes, people likely to work in hotspots, people in public housing. And if that's the way it remains, then the policy response could be the opposite of what you suggested. It could be guarded gate and protect ourselves. And this is something that people don't feel threatened by or connected to as time wears on. On the other hand, we have 9% of the public already knows someone who's died from coronavirus. That number's only going to get bigger. I don't know how big it's going to be, and I don't wish it to be bigger. But to the extent that it connects to people and they feel like this was something that was an existential threat to them and their families, I think our policy response is likely to be more comprehensive. Still, we're going to have the problem of our Congress doesn't necessarily reflect our views when it comes to healthcare. I don't think that's going to change overnight. I think, Mitch McConnell is still saying this is a blue state bailout and New York should declare bankruptcy. I don't think our politics are yet changed forever. I wish I could give you more optimism that they were. And I'm not picking on Mitch McConnell. I'm just suggesting that the acrimony is still there.
I just wonder, though, looking at it through a historical lens, I guess it sounds like what you're saying is we don't yet know kind of the scope, right, of these sorts of changes. But, with Donald Trump referring to himself as a wartime president, I mean, if you look back to post-war eras, or certainly, politics after the Great Depression, I think we have seen more of a movement toward more robust social programs, maybe not for everyone, but certainly for some. It doesn't sound, though, like you're saying that you think this will be the thing that pushes the U.S. toward single payer.
I'm saying that there's people who assume it's going to happen automatically, I think are going to, whether it's the progressive era, the civil rights era, whatever you want to point to, those things happened. There were still people sitting in Congress in 1965 voting against Medicare and Medicaid and Social Security in the 30s. And so it absolutely, look, the message that we should all get from this is, look, we're only as healthy as our healthiest neighbor. The person you're sitting on the bus next to or on the airplane next to, when there's an infectious disease, that's going to be important to your health. So there is a message, and I think the public will generally get that message. I also think there will be a sentiment of hunker down and fear and separation and protect myself from people who can. I don't think those dynamics automatically change overnight. But I do agree with you that, if you look over maybe the next decade and you look at this current younger generation getting older, having more of a say, and I think that I do believe that those things are an inevitable part of the next era. But I also don't think that we're going to learn the meta lesson from this instantly. We're going to learn like we did with 9/11. I think we're going to learn the very tangible lessons. Like we'll have more N95 masks in this country than we have, anything else, right? We'll never run out of the things we ran out of this time. We'll learn those lessons, but it remains to be seen whether we learn the broader lessons. Kind
of continuing on the insurance question, when I interview doctors, healthcare providers, there's kind of this growing push, certainly from the primary care doctors, to move away from what has, historically been the insurance model in the U.S., which is a fee-for-service model, meaning, a doctor gets paid for the individual procedures that he or she performs on a patient. Nowadays, people aren't going to the doctor. I mean, we've seen there's a study from the Commonwealth Foundation that showed pediatrician visits are down more than 60%, and some specialists are down even, almost 80%. Should we be talking about changing the ways that insurance pays doctors so that when people can't make those visits, the doctors stay open? And should we be talking about it right now, as in making those insurance companies pay the providers? Yeah.
Yes, we should.
And who has the authority to do that? I mean, how does that change happen?
Yeah. Well, let me start with the problem. We are, physician practices, small practices, family medicine practices, dentists, Medicaid providers, mental health specialists. I mean, they have typically less than a month cash in the bank on a normal kind of course. And, some of the estimates are that we'll lose 12% a month of these practices. And think about it, we're going to be entering a period of time when we come out of this when prevention is going to be vital, because with infectious disease, we're going to be focusing on need to focus on all kinds of measures. Now, I will say that some of the reduction in utilization is bad, and some of it probably isn't. So I believe that any loss in the primary care, anytime that to me, that's all stuff that should be going on. Mental health care, we're well short of that anyway. Pediatrician, well baby vets, all those things we should be more, not less, and that is a loss. Some of that, I think telemedicine will permanently increase access points for, I suspect, and I think that's a good thing. But turns out, a lot of and some of the things that people call elective are really not elective, right? Some of the things not happening need to happen. I know people, and you probably do as well, who have cancer treatments that are getting delayed and things like that. But there's a lot of stuff that is done in hospitals that it's just done purely for revenue basis. And I think some of those things are a reflection of the size and the scope of what the kind of medical establishment does. And readjusting their size, not the way it's likely to happen, but readjusting their size wouldn't be the worst thing in the world. The way it's unfortunately going to happen is the HCAs of the world aren't going to have the problems. It's going to be the small rural hospitals are going to be challenged.
But wouldn't it be a problem if hospitals were reducing their size now? I mean, given that sort of hospital capacity, how many beds they have for a potential surge of patients. I mean, that was kind of dominating, the headlines for a long time. Certainly in New York, we saw hospital capacity stretched thin. Is there a way that you can reconcile those two things? Yeah.
Sure. I mean, look, you don't want to staff a bunch of empty beds all year round for 10 years waiting for this. But you do need the ability to create surge capacity. And look, with a little bit of planning, I mean, remember this hit us. We started planning for it after people started getting sick, right? And that's really hard. I mean, if we had been anticipating this even for a few months, we would have been able to stand up surge capacity and other kinds of capacity much more quickly. If we'd have kept our stockpiles up, which I suspect we'll do in the future, that would have been certainly a good thing. We didn't, and so we were building tents on the fly. And the truth is, great credit to the people of New York and New Jersey and Michigan. They did that, but what was even more incredible was that people actually reduced the need for those beds by dramatically reducing the infection rate with the hashtag stay home. So everyone should feel at some level a sense of pride that we prevented the worst from happening. But yes, I mean, there are going to need to be surge capacity facilities for infectious diseases and things like that. But the day-to-day community hospital, I don't think we want them carrying 20% extra cost year round for that. We're going to need to carry that like on the government's balance sheet.
Mm-hmm. I mean, it is a fact that hospitals in this country are businesses and they need revenue to run. Should we be, or how can we sort of disincentivize them from keeping their beds full? And is that even the right, is that the right metric that we should be aiming for, as far as policy goes?
Look, I think coming out of recessions like this, demand is slow to pick back up for almost everything, for consumables, for services, and for healthcare utilization. In 2008, 2009, pre-2008, 2009 levels of demand really never came back. There's a variety of reasons for that. And I'm sure you've got a lot of people listening in here who can point to a number of reasons. So it's not a simple story. But people are slow to spend when they've gone through financial trauma. And so I think the demand for certain things will be lower. That will run into a system where, just as an overly simplistic example, hospitals will want to start ramping up those CT machines and run a bunch more tests and all those things. And again, I'm not accusing anybody of anything. It's just how the system works. But the demand will be down, and I think it's only with the demand down that we'll see adjustments. Again, unfortunately, those will be uneven because the places where we need more capacity, safety net hospitals, aren't going to be the places that necessarily, they're going to be places that suffer. Rural hospitals, which already are low capacity but required for critical access, they're in really significant, difficult financial situations. So, it's going to be messy. Technology can help with some of it, but not all of it.
Yeah. I just want to return to the insurance question where I asked, and I think you were nodding your head yes, but correct me if I'm wrong, that essentially insurance companies right now may be collecting premiums from people who are not necessarily going to the doctor, as we're seeing. A lot of these doctor visits, hospital visits are down. Should they be forced to kind of share the love? Send some of those payments to providers despite, no services? And if so, who does that? I mean, is that a CMS question?
No, CMS controls the public payer programs, but not, this would have to come from, putting aside the how first, what I think is going to happen instead is, I'm afraid is going to be even worse, which is that insurers are going to use this as an opportunity to buy physician practices themselves. So I think they view it as in their interest to have them struggle, and then they will buy some of those practices. So Blue Shield just announced it was buying Brown and Tolan. This is in California, Blue Shield of California, which is a incredibly significant disruption. That one of the most largest independent practices is now owned by an insurance company. So insurance companies, as you've said, with this drop in elective services, they're just seeing fatter and fatter bottom lines. Some of it they may give back as COVID cases spread to their population, but the average COVID case is only about $3,000, which is expensive relative to other infectious disease like the flu, but it's not. And so the network that we all rely on, not just primary care docs, but I worry about mental health professionals and I worry specifically about Medicaid providers. They need to be kept in business. So, I have asked and I have called for the insurers to do some sort of creative financing where they say, we're going to forward to you some of the money we would have paid you. And over time, if you have, we'll forgive some of these loans with high quality results over time, and otherwise we'll make them kind of long-term loans. Sadly, I don't see insurance companies doing that because I think they've got a different preferred approach in general.
It's interesting. In Texas, generally, when we talk about Medicaid, we're hearing from politicians who are referring to it in less than positive terms. It's a bloated program, and it's a program that you cut from. Generally speaking, from legislative history here in Texas. But even despite all of that, we have actually seen the news, I think last week, was that even Texas Medicaid was going to boost its payments to providers. Basically, a reflection of the fact that nursing homes, hospitals, you name it, need some assistance right now, and the Medicaid program can pay for it. I wonder if the private plans then follow suit, but it doesn't sound like it.
The Earth is off its orbit. Look, they should be pressured to do it. There's a lot of pitching in that we all need to do, and I don't think there's going to be a lot of tolerance from the public for people who take advantage of the situation. There's not always a lot people can do about it. But, I spend part of my day chasing after profiteers in this climate, and there's some ugly stuff that goes on when you have shortages in black markets and things of that nature. Right now, I would think, for my time in government, people rarely came to me and said, can I spend more money to help things? They often said, hey, this nickel that I used to have when you reformed something, I want it back. By the way, I'm going to walk into my office to plug this in. And so anybody who it's going to take a second, but if you get dizzy watching me walk, then, close your eyes or get a drink.
Yeah, no worries. I'll take over. The kind of in line with what we were talking about, just as far as the consequences on the primary care network, people aren't going to the doctor, including the pediatrician. There was one alarming headline in the New York Times this week about how vaccination rates for children are falling. As a policymaker, how do you, or really as a politician, I think right now politicians are trying to send the message of you must stay home, but how do you balance that with, but we still need you to be taking your kid to the doctor to get the shot? I mean, how does that messaging work, and how do you incentivize the policy to fix a problem like that? It seems like vaccine rates going down now in a public health crisis would be the worst outcome that you could ask for.
Right. Look, I wish there were easy answers to these things. I wish our kids could go to school. I wish I could watch pro basketball. I wish that small businesses weren't suffering. I wish that people weren't dying from other causes besides coronavirus, which I think is increasingly happening. I wish there was a mental health impact to all this stuff. And I wish my wishing could change anything. The truth is we're going to have to do the best we can, and we're going to have to get creative and adapt some out-of-the-box solutions and thinking to these things. And that takes a little bit of time. I suspect, if we're sitting here 6 months from now, there will be some solution to vaccinations that will allow parents to feel safe. These aren't anti-vaxxers, right? These are people who are worried they're going to take their kids in and their kid's going to get infected, or they're going to get infected. So somebody will come up with a way for it to be done safely. Sadly, it's probably item 700 on the list of 7,000 things that are being disrupted right now. Mm-hmm. And so I'm not suggesting it's not important. I completely agree with you. It is exactly the wrong thing to be happening right now. But I think,
we've seen schools get creative with delivering Wi-Fi, via buses, delivering meals, that sort of thing. I mean, is this a question for the public education network to sort of, in other countries, Australia, for example, most of their vaccination occurs in schools. I wonder if that's a conversation that the United States should be having.
Look, I mean, we live in a more immediate, not to dodge your question, I don't think there's a great answer, but there's a more immediate crisis, which is going to be food. Mm-hmm. And, I've been spending a lot of time with Chef Jose Andres recently. When schools stop getting their funding over the summer, and they can't pay kitchen staff and they can't pay for the meals, we already have 40 million Americans that are hungry or on the edge of hunger. That number is growing. We haven't had a hunger problem in this country in quite a long time, and it's not for lack of food. It's for lack of market and distribution, and a lot of long haul truckers are just no longer in the game. And we created a world for ourselves where we were dependent on globalization and just-in-time inventories to get stuff cheap. And that was kind of the world we've lived in, and we can all count the ways it's made our world better. But we also didn't carry inventories of much. And when you barcode everything, you can't take a bunch of rice and beans that you send to restaurants and send them to grocery stores because they don't fit in the truck, and they just don't know how to do that. Some of these things are going to get figured out, for sure. But also in the process, there's going to be a lot of collateral damage, restaurants going out of business. But turning restaurants into places where people can use SNAP, allowing people, all those kinds of things are important solutions. But if I call a congressperson and Jose calls a congressperson to talk to them about this, it's like, I got 75 items for the next bill, and this sounds important. and we'll try to get into one of the future ones. And by the way, everything's got a price tag. And in the meantime, there's a lot. So
It seems like an example of the pitfalls of planning during a pandemic rather than beforehand.
Yeah, exactly.
I would like to spend, we've got about 10 more minutes here. I'd like to spend the last part of it really talking about two issues that are top of mind right now, which you alluded to at the beginning, which is increasing testing, getting more people tested, whether that's antibody testing for, from, serology testing of the blood, or the more sort of traditional tests, nasopharyngeal swabs, to see if there's virus in the body. How do we solve that problem, which, according to my reporting, and I think, I think most people would agree at this point, it's really kind of a supply chain issue. It's we don't have enough reagents and enough lab workers, for example, running these sorts of tests. How do you solve those problems now?
Right. So let's just step back a second. Tests were not designed to be done at massive scale. The testing, the sort of laboratory tests were designed for you to go get your cholesterol checked once a year, wait a few days to get a result. And, there are some high-speed tests, but that's, they're not, it's not what we've always expected in the lab industry, right? So you add to that we were asleep for the first couple months of this while the world started competing for reagents and swabs and other supplies. And the CDC test came out late. The CDC test is okay, but the CDC asked the commercial labs not to produce their own tests. So now, like everything else, we're playing catch up. We're swimming after a speeding boat, hoping we can somehow catch up with this problem. And every day we have way more people testing positive than we have tests. And we know there's about 10 times, if not more, people who are positive who are untested and who are, sadly, we know they're infectious. So we have to do two things at once. I mean, we have to really work on the kind of nuts and bolts issues, which I would call, we got load balancing issues. We got with supplies. We've got reagents that only come with certain machines. And it's sort of like the Gillette razor and the Gillette razor blade. They only fit each other. Here, we've got FDA's only approved certain swabs for certain machines and certain reagents for certain machines. So it's not built for a crisis. It's built for like an ideal situation. So by changing some of those things, by rebalancing supply, by setting a higher price, you can go from about 1 million tests a week to call it 2.5 to 3 million a week. You probably need to be at least 7 million to start to be where you want to be.
So you say setting a higher price. Is the implication being that you need to do that in order to have more sort of market?
There's a lot of lab capacity that's not being used because we're not getting demand signal. I know it's going to piss a lot of people off, but the biggest lab companies in the country are only producing about half of the capacity they have. They have the reagents, they have the supplies, they don't have the orders. So we as a federal government can step in and backstop a bunch of orders, or give the states the money and have the states backstop the orders. That hasn't happened yet. I suspect that'll get worked out slowly, more slowly than it should. But my point is, through a series of things that are relatively controllable, by the end of the summer, you can be at 2.5 to 3 million. The rest of the way is going to be, you're going to need some things out of the FDA. And I think there are some higher speed machines to be approved. There are these point of service diagnostic tests, which are faster and cheaper. Their sensitivity is not necessarily great. And then on the serology test side, which is the other thing you referred to, one of the things we've asked of the FDA is that they move fast. And so they've done a ton of emergency use authorizations. Not all of the things that they've approved are that great, but there are a couple that are. I don't think it's going to be as important for quite some time because I think the herd immunity levels, even if they're 10 times higher than the number of people tested across the country, are about 2%, and most of that's New York, where it's 15 to 20%. Mm-hmm. So, I don't think we will have serology tests to figure out who's had immunity, who's got immunity, but that's, I think, a secondary importance right now.
The other sort of capacity question that keeps coming up, and which the former CDC director Tom Frieden has talked about, is the lack of workforce for contact tracing. So these are the people who, when there is a positive lab test, they call that person and they basically, interview them for hours and say, where have you been? Who have you talked to? That sort of thing. That's maybe not the most gracious description. My point being, it is a very intensive process. It takes a lot of time and a lot of manpower. Dr. Frieden has called for, I think, essentially 300,000 more of these individuals in the U.S. In Texas, we're aware that a lot of this work is being done essentially by volunteers or med students or grad students. I don't see that as sustainable over the long term, and I wonder how. Well, do you agree? I mean, should we be hiring more contact tracers, and if so, who should pay for that, and how do we ramp that up quickly?
So we believe, and by we, Scott Gottlieb, myself, a bipartisan set of folks have worked on this, and we're going to be putting it forward to Congress next week. We need about 100. We think we need about 180,000 contact tracers. The truth is, the number is entirely dependent on the case count, but it's about 11 person days per case. And so you listen to that and go, wow, it takes 11 person days for a case? So just try it. Okay, just try it. I talked to Seth Doan, who's the CBS Rome correspondent who tested positive for coronavirus. I asked him to just tell me if he could remember the people that he came in contact with before he was diagnosed. He started naming a whole number of people. I couldn't even write them all down. I just took the first person on that list, who he said he had breakfast with, who was someone I knew. I called that person, and he said that, yes, Seth had called him and told him that he had tested positive. I said, what did you do after breakfast? He said, after breakfast, I went to a meeting with my entire company in my conference room, about 40 people. We fist bumped because we thought it was safer than shaking hands. Then I went to see my 85-year-old mom that night, and I stopped right there, right? Like I was like, I'm done. I can't do this. So you think about it, is a lot of manual work. That's the first step. The second thing you need is when you find people who are test positive through the contact tracing process, you have to offer them a way to voluntarily self-isolate. If they live in a one-bedroom or they've got kids at home or parents or whatever, so we are proposing that you make hotel space available for people who want to voluntarily self-isolate. And then the third is that there be some form of income replacement because people aren't going to miss income to do this. So we're proposing that something equivalent to a jury duty payment, because it really is you're performing a civil service, whatever. You're performing something nice for the country if you stay home, and so there has to be some sort of an income replacement. So that's not cheap, but it is an important containment tool, like you said.
If you had to, it sounds like this is something you've studied. What do you think the price tag is on that?
It's about $50 billion.
Well, we're about out of time. Mr. Slavitt, I just want to say thank you so much for joining us, and to all our viewers, thank you very much for tuning in. And of course, thank you to everyone who's supported today's event. A little plug here: to keep tabs on the latest coronavirus news in Texas, you can subscribe to our evening newsletter, which is at trib.it/coronavirus. Have a good rest of your day, and thanks again for joining us.